From above, the surface of a body of water can appear perfectly still, but drop just a few inches lower, and the currents are churning violently. For decades, the psychiatric field has viewed adult autism from the surface. Standard clinical assessments rely heavily on observing external, visible deficits to determine a diagnosis. Clinicians look for specific behavioral markers defined in the DSM-5, such as deficits in social reciprocity or abnormal eye contact. If an adult patient successfully mimics these conventional gestures during an evaluation, they are frequently ruled out for an ASD diagnosis. This Prisma flow diagram from a 2023 systematic review by Alagaband Rad and colleagues shows the 16 specific studies isolated to map the mechanics of adult camouflage. This review shifts the focus away from pediatric observation. Instead, it aggregates data on how adults internalize and manage their traits to navigate neurotypical spaces. The findings show that an absence of observable autistic traits does not indicate a neurotypical brain. Rather, it often masks an active process of social camouflaging. Relying solely on outward behavior creates a structural blind spot, leading to a systemic crisis of misdiagnosis in adult populations. To measure this process, researchers developed the CAT-Q framework, which categorizes camouflaging into 3 distinct cognitive nodes: condensation, masking, and assimilation. The first node is compensation. This is an active intellectual loop where a patient scripts conversations in advance or meticulously observes peers to copy their body language. The second node is masking. This functions as a filter used to suppress outward signals, such as forcing eye contact or consciously inhibiting self-regulatory stimming behaviors. The final node is assimilation. This describes the behavioral techniques used to fit in, where an individual performs a neurotypical persona specifically to avoid social rejection or bullying. These internal processes are invisible during a standard evaluation. To find them, psychiatrists have to calculate the discrepancy between a patient's internal experience and their external presentation. This is expressed in a quantitative model. The camouflage index is found by subtracting the ADAS score from the autism quotient, or AQ. By taking the self-reported internal traits and subtracting the observational clinical score, researchers can measure the exact delta, the amount of work the patient is doing to hide their symptoms. This establishes camouflage as a measurable mathematical discrepancy rather than an anecdotal observation. When these metrics are applied across the population, a sharp disparity emerges. Camouflaging is significantly more prevalent in the female ASD phenotype. This highly developed ability to blend in is the primary driver of delayed or missed diagnoses in adult women compared to men. Research by Meng-Chuan Lai and colleagues links these behaviors to specific neural activity and structural variations in the brain. In autistic women, higher rates of camouflaging correlate with increased neural responses in the ventromedial prefrontal cortex during tasks involving self-representation. There are structural differences as well. Higher levels of camouflage in women are associated with smaller anatomical volumes in the medial temporal lobe and the cerebellum. While autistic men also engage in camouflage, qualitative data shows they often do so for distinct reasons. Men typically camouflage to increase their comfort in social interactions, whereas women often utilize it as a functional survival tool in professional and educational environments. Female camouflaging is a neurobiologically taxing profile that effectively hides clinical severity from observers. Maintaining this cognitive architecture over a lifetime carries a staggering mental health cost. Data from Beck and Cassidy shows a direct correlation between high CAT-Q scores and psychiatric morbidity. As the effort to camouflage increases, so do the rates of generalized anxiety, clinical depression, and psychological distress. At the highest levels of the index, camouflaging traits become significant predictors of thwarting belongingness and lifetime suicidality. This creates a clinical paradox. The very strategy used to function and blend in is the primary driver of autistic burnout. Observers and clinicians often mistake this masking for overcoming autism, missing the internal crisis building behind the performance. Eventually, the physiological cost of maintaining that internal tension reaches a breaking point. Outward social assimilation is not a marker of psychological health. In adult autism, it is frequently a warning sign of imminent psychiatric collapse. The identification of camouflage shifts the clinical understanding of high-functioning autism from social performance to internal cognitive load. A patient's ability to seamlessly assimilate into neurotypical spaces is no longer a valid measure of their clinical status. Moving forward, the diagnostic model must evolve from simple observation to a dual approach that accounts for both presentation and internal load. To correctly identify the hidden female phenotype, clinicians must explicitly probe for masking behaviors. Integrating self-report tools like the CAT-Q into baseline assessments is the only way to prevent further generations of misdiagnoses. Short-term social blending is a compensatory survival mechanism, not a lack of autistic traits. Dismissing a patient because they look normal is a failure of clinical rigor. Effective psychiatric care requires looking past the socially acceptable mask to treat the immense cognitive cost of wearing it.